Okay, guys, we're going to carry on here. And the next presentation is Cannabis Pharmacology. And I'll be doing the second part of that on drug interactions. So the presenter that we have next is Shrag Dave. Shrag is an experienced pharmacist. He graduated from a Doctor of Pharmacy program in New York. He's been an active community pharmacist since 2013. He's also he has an interesting story. He became engaged in the Canadian medical cannabis industry in 2014 after he was diagnosed with Hodgkin's lymphoma. He wanted to get relief from the chemotherapy and radiation treatment that he was getting, and being a pharmacist, he became quite frustrated that there was no medicinal cannabis for him to use at the time, and so he began this process of learning about cannabis and understanding its titration and the science behind it, and some of which we talked about today. He also was involved in a health technology startup company and ACMPR licensed producer, where he was director of clinical affairs. And he's currently active in the industry in various aspects. And we'd like to welcome Shrag up to the stage.
This on? Yeah? Okay, I can hear it. Alrighty, so thanks for having me today. You'll be seeing me today and tomorrow. I'm doing 3 modules on cannabis. The first is on pharmacology, the second is on the evidence base. That's a little dry, I'm gonna warn you. And the third is how cannabis relates to the community pharmacy and what are the opportunities for all the pharmacists in the room. So with that being said, we'll start off looking at the pharmacology of medical cannabis. Learning objectives: understand the endocannabinoid system and its interaction with the cannabinoids. Explore the various compounds within the plant with a focus on THC and CBD, the ones that everyone talks about. Explore the PK and PD data available for medical cannabis, and identify any expected effects or adverse effects in patients using medical cannabis. We're doing a bit of that today, more so tomorrow. But you'll see as we progress where effects and side effects may happen. Okay, so I know you've seen this today already, but repetition is a good way to learn something. The endocannabinoid system is the system in the body that interacts with endogenous and exogenous cannabinoids, the ones that are in our body and the ones that are outside of our bodies. The system plays a role in, I've listed 5 things here, but there's many things it plays a role in. Pain modulation, controlling of movement, memory, immune function, GI function, and et cetera. The constituents of the system, so the 2 main receptors that Dr. Price were talking about, the CB1 receptor and CB2 receptor. There's actually a CB1RB receptor, a subtype, but you can lump it all together. And even more so, there's the other receptors, like Ira mentioned, the TRPV1, G protein coupled receptor 55, and PPAR nuclear receptor. The endocannabinoids within the system, anandamide and 2-AG, so we've put abbreviations to make it simpler. And the synthesis enzymes, the ones that make the cannabinoids, and they're made on demand, like Dr. Price said, they're not just sitting around at all times. NAPE, PLD, and DAGL, and the degradation enzymes, FAAH and MAGL. And I don't know if you remember, a few years ago, they tried a FAAH inhibitor drug that had some very negative side effects, which was stopped. Let's see. Yep. Okay. I like this little summary table. It's a good take home for you guys. Looking at just CB1 and CB2 receptors. So the primary location of the CB1 receptors, we can just say central nervous system as a blanket. The primary location for the CB2 receptors is the periphery in the immune cells. Anandamide, you can see it's a partial agonist with high affinity at CB1 and almost inactive at CB2. 2-AG is both equal at full agonist with low to moderate affinity at CB1 and CB2. And now THC and CBD, the most interesting ones. THC is a partial agonist with low to moderate affinity at CB1, and similarly the same at CB2. And like Dr. Price said, it has negligible affinity at either. So that makes you wonder, well, where does it work? And I know he mentioned it, but CBD is actually an allosteric modulator of THC. So that's just one effect. And the second is that it also binds to the nuclear receptors, the PPAR receptors. Similarly, THC is a positive allosteric modulator at opioid receptors, which is why patients taking cannabis often can decrease their opioid doses because the THC improves that process. Moving on, I know Dr. Price gave you his excellent spiel on this, but I'll sum it up. Cannabis is a plant that's been cultivated for thousands of years for medicinal, spiritual, and recreational uses. We use the word cannabis because the word marijuana has been stigmatized. So when you see it in the news as marijuana, there's definitely an angle being taken there. It's been in publications for a long time, but the USP 3rd edition in 1851 is the most notable one. The plant itself contains 100 different cannabinoids, 100 different terpenes. So these are the essential oils that confer the smell into the cannabis, and flavonoids, which are signaling molecules and pigmentation molecules. The genetic subtypes, we have indica, sativa, and ruderalis. And out of this combination of all these cannabinoids, all these terpenes, and all these flavonoids, we have the thousands of strains. I put hundreds, but there's probably thousands. Okay, so usually I have this slide more colorful, but you can use your imagination. So pinene, what does it sound like? Sounds like pine, smells like pine. Limonene smells like lemon. And it goes further down, humulene, myrcene, and caryophyllene. So these terpenes don't only confer smell. There's a thought that they have pharmacological activity, and we know we have an idea, weak evidence, that myrcene is an analgesic, it's a sedating. Limonene is an antidepressant. Pinene is an acetylcholinesterase inhibitor. Caryophyllene is an anti-inflammatory. So this information is out there. It's weak evidence and it's in vivo evidence. So take it as you will. A lot of what is being put out there is weak evidence, but that doesn't mean it's true or false. And the flavonoids we have listed, apignin, camphorol, etc. These also may have activity on their own. Like I mentioned in my previous slide, some preclinical data suggests that terpenes and flavonoids possess pharmacological activity, analgesic, and anxiolytic, anti-inflammatory, gastrocytoprotective, antioxidant, antifungal. And this has been recent understanding that's come out in the past few years. The terpene and flavonoid profiles are what differentiate one strain to the other. So it's not necessarily the indica, sativa, ruderalis that does it, but it's the constituents of the entire makeup of that plant that make this plant effective for this condition and this plant effective for that condition. Push. Okay, so here's some more word salad for you guys. Cannabinoids, I've listed about 10 here. There are 100 plus, but these are the most popular ones. THC, tetrahydrocannabinol, CBD, cannabidiol, CBC, CBG, CBN. It's all news networks here. And then we have CBGV, THCV, etc. In practice, we've mainly seen strains cultivated for THC and CBD. I do know that there are some licensed producers cultivating for CBC, CBG, and CBN. And we're going to see more and more come out once more dedicated science comes into this field. Cannabinoids are typically found in their acidic form, which means they need to be decarboxylated. And our lovely vaporizer team will explain how the vaporizers do decarboxylation. And cannabinoids, I don't want to step on too much thunder here, but cannabinoids have various temperatures of decarboxylation. Not all are just at X Fahrenheit. It's varying for each cannabinoid and each terpene as well. Like you probably already know, CBD has little to no psychoactivity, and similarly CBC and CBG also have little to no psychoactivity. Something I like to highlight, THCV, some preclinical data suggests that it has anticonvulsant activity on its own, and some data suggests that CBG is antifungal, as well as a few other things on its own. Okay, so I said THC and CBD are the most commonly bred and expressed. Very interesting to me. I worked at a licensed producer, so I always tried to spend time in the back, getting to know the process, getting to know the plants, and really what starts as a seed or as a cutting into the medicine that we see today. Various things affect the concentration of cannabinoids, and it's hard to get it consistent, and which is why oils and other dosage forms are good solutions for consistency. Genetics, plant age, growth conditions, harvest time, and storage conditions are just some of many things that affect concentrations. Do ask the growers. If you go to the Green Relief Tour, ask them other factors. Once we decarboxylate the cannabis, they're more active in the body and interact with the endocannabinoid system and other pathways. And cannabinoids amongst the other group of compounds are considered the primary active component. Okay, so you hear about delta-9 THC. Delta-9 THC is the active form, and it's primarily the psychoactive component. Data suggests that it's analgesic, antiemetic, helps with sleep disorders, and anti-inflammatory. But I put the ... because there's a huge list of things, and we can go more over that tomorrow. CBD, cannabidiol, it's a non-psychoactive form. The molecules actually look very close to each other, and it attenuates the psychoactive effects of THC. And as you all know about Epidiolex, CBD is the primary component within GW's Epidiolex. Data suggests that it's anti-epileptic, antipsychotic, provides antispasticity effects, and is anti-inflammatory, but the list goes on and on. Switching gears a little bit, we're going into a little more of the science, not too dry yet. In terms of absorption, cannabinoids are highly lipophilic and have low water solubility, which is the challenge in getting these things into dosage forms that people like. We know today cannabis is available in an oil, and I know that some companies are working towards putting cannabis into oil water suspension so that you can actually have it in more palatable dosage forms. Has a large volume of distribution, highly protein bound, and absorption varies very wildly and widely. Orally, it's about 20 to 30% available. I like to call it an average of 20%. By smoking or by inhalation, which combines smoking and vaporization, I've seen numbers of 10 to 60%. You can call 30% a good average if you wanted to market somewhere. And the reason why it's so varied is because it's affected by depth of inhalation, breath holding, which Ira was talking about, and temperature of vaporization, but there's more and more factors to it. Okay, distribution. So it's distributed to adipose tissue, liver, lung, and spleen, and it can release from adipose tissue weeks after cessation. So I'm sure patients will ask you about how long is cannabis going to show up in a drug test if they're going for a drug test. Well, the reason why it can show up many, many days after is because it releases from adipose tissue over time, and more so when you are a big-time user. Has complex metabolism, mainly through the liver, allylic oxidation, epoxidation, decarboxylation, conjugation. So I put the main cytochromes up here, 2C9, 2C19, and 3A4. Pram will go over more clinically relevant interactions. Just because it's put through these cytochromes doesn't mean that it always has clinically relevant interactions with other drugs. Some more numbers here. The time to max plasma concentration for THC is about 3 hours in the blood and 15 minutes in oral fluid. And the CBD Tmax, and a lot of these numbers that I got from for CBD are from Epidiolex's numbers, which are rather recent. The Tmax for CBD is about 2.5 to 5 hours at steady state. They saw in their studies that co-administration with a high-fat meal, which Epidiolex is an oral product, co-administration with a high-fat meal increased the Cmax 5-fold versus fasting, which is very significant. Okay. Some of THC's primary metabolites. The equipotent one is the 11-OH THC. It's the longer lasting metabolite, and it's the one you see more so when you ingest cannabis orally, which is why ingesting cannabis makes it last a lot longer than if you were to inhale it, which I like to say inhaling is fast on, fast off. It's like short-acting insulin, and oral cannabis is like long-acting insulin. And the delta-9 THC COOH, that's inactive, and that's the one they use for diagnostic purposes. CBD's primary metabolites mirror a very similar thing, 7-OH CBD and 7-COOH CBD. One is active and one is inactive. And it also produces the glucuronide conjugates, and that's done through phase 2 metabolism. So I'm sure your brains are probably going about drug interactions now. Excretion-wise, THC is primarily excreted in the feces, 65%, less so in the urine. The 11-OH form is the predominant form in the feces, and the glucuronide conjugate is the predominant form in the urine. And CBD, with the new data that we have, is primarily put through the feces. So I know I blew through it really fast, but if you have any questions, you can definitely ask me right at the end. To wrap it all up, cannabis products, oral or inhaled, are primarily interact with the endocannabinoid system. We've seen that. The products itself may have many chemically active components, and the components within the plant, we just looked at THC and CBD, but there are many more that all have their own PK and PD properties that affect the activity of each other. Tomorrow we'll go more into the evidence and more into the drug interactions, adverse effects, and that kind of thing. So if you have those kind of questions, you can save them for tomorrow. But anything about this, do let me know. You know, and Ira, you can help me on this too, but I've seen in practice that patients taking cannabis on an empty stomach, the oil actually get irritated because it's like crushing olive oil. It wouldn't feel very good, right? And a lot of the licensed producers can speak to this too. A lot of the cannabinoids are suspended in sunflower oil, olive oil, et cetera. So you do want to take it with a meal. But like I always say, consistency is important. Like if you take your thyroid pill in the morning with food, take it in with food every morning. Don't just say empty stomach one day. I saw a question somewhere over there. No? Questions? No? Okay, thank you. Appreciate it. Oh, yeah?
Yeah, like it's people, we talk about coconut oil being amazing, but it's a fully saturated oil, which isn't always good for you. And so we have to be careful with which oils we're even using, which oils the LPs are using for the suspension of their formulation. Those things are really important. Some use sunflower oil, some use olive oil, which is a polyunsaturated or monounsaturated.
Yeah.
And which means you don't want to heat it up because then you release free radicals. And then there's grapeseed. And so we have to be really careful with which oils we're using. People are, they're using a lot of coconut oil, and a lot of the LPs are, and then people's liver enzymes are going up. I mean, it's transient if they stop using the oil, but we have to be kind of careful about this.
Yeah.
I know it's not dose dependent, no, because it's suspended in oil. So like you're literally like 30. I don't know how many ml, but let's say you buy a 60 ml bottle of oil. I mean, you're using this 3 times a day. Is there cholesterol going on? I don't know. Good question. I have never tested anybody's cholesterol on, but I'm assuming that it's potential. I don't know how relevant cholesterol is, but yeah. You guys look at big class.
It does become like you do end up using a lot of oil every day over many days. But we'll see with the next 2 years of legalization and how it rolls out. The other dosage forms will be coming out and allowed that are more concentrated. Like right now, the cannabis oil is concentrated at a max of 30 mg per ml of THC. And that isn't much. Like clinically, that isn't much. And tomorrow we talk about dosing. And I give you a very conservative dosing, but patients really have to go much higher than that in practice.
You could use an emulsification. That's what they're using now. We have this thing Dynamix and all these other mixes.
Yeah.
That can emulsify your fat in a solvent and make it water soluble and sort of, I don't know if it's really your fat, but it's an emulsifier. So, I don't know.
Yeah. Saw a question back there.
If you're doing just sublingual, so if you're sort of not like a wafer or something versus injection, do you think that would change the pharmacokinetics?
Yeah, I mean, it'll be faster on for sure. Any sublingual thing that's formulated properly will be faster on. It probably lasts a similar amount of time though too. But you can't get any wafer forms in Canada. If you go to Vegas, you can get everything. No, I heard. Yeah. I'm talking about cannabis, but yeah, all the dosage forms are available in Vegas. So that's a very interesting question. I haven't seen any data out on the PK of transdermal use. I myself am going to be dabbling in that direction. So when I have data, I'll pass it on to NAC and they'll pass it out. But transdermal use is an area of a lot of interest. And I don't know, I used to work with Dr. Price in the clinic, and we had the same patients. And I think some of our patients actually did do transdermal or topical cannabis. But they found benefit from it. Like they slapped it on and it worked.
Yeah, I think your bioavailability is pretty high, so.
Yeah.
But and then again, who knows, because those formulations weren't even technically legal.
No, yeah, and they were inconsistent.
And they were getting them from who knows where, so it's super inconsistent. But
The
you can make it.
yeah,
So you can make it you can change it.
yeah, you can suspend
You
it.
just have to make it water soluble. Or add a protein carrier to pull it across, like a DMS.
Yeah.
Or a little.
And people using emu oil, actually. Emu oil is a popular one. That's a very good and technical question. That's a deep technical question. I think we'll see that with time. But I know like the $1 million science right now is into making cannabinoids water soluble. That's where the money is, and that's where you can make beverages. That's how beverage is good. You're not drinking oil, it's a water soluble form. Any other questions? Okay, thanks a lot. Oh, I didn't do it. You want this thing? Okay. I'm gonna sit up here. Or? Sure. Yeah, just to answer any questions.
I just want to take a moment to recognize some of the staff that are here today from NAC. We have Chris Kane there in the background. He's our COO, and we have staff from the clinics here as well, sitting at various tables. Our cannabinoid therapy educator, we have our VP of marketing, Matt Ryan, Evan, Ailey, Jane, am I missing anyone? Joanna, our educator is Sarah, and then back there, if you just want to wave to everybody. There you go. So they're going to be helping you out shortly in regards to vaporizer use. So they have a ton of experience actually educating patients on a practical level. A lot of what we talk about is theory. Since cannabis isn't dispensed through pharmacies yet, pharmacists in general haven't had the kind of access to patients to actually counsel them. So for the last number of years, the individuals that have been doing that are the cannabinoid therapy educators and cannabinoid therapy assistants. And so they have a lot of great practical knowledge that, through NACM, any partnered pharmacies or physicians can kind of draw from. And we have Dr. Gorlick over there, who is
one of our main physicians, and I think he can attest to the CTAs and kind of what they bring to the table. So I'm just going to go through medicinal cannabis and drug interactions. So it's a topic that is always of interest to pharmacists, and actually generally should be interest to everybody. So the issue with drug interactions and the knowledge base is that, first of all, there's not a whole lot of well-documented interactions. Now, partly that's because the drug was illegal for many years, and even in legalization, it's run through LPs and not through a traditional system where hospitals or physicians' clinics or pharmacies have been involved, and so you might not get the level of drug interaction documentation and kind of sending that over, or ADR reports, sending that over to Health Canada that you might otherwise have in a broader system. So we have a limited number of documented interactions. The other thing is a lot of these interactions, when you start researching them or kind of looking them up, there's no information on the route, on the dose, on the chemotype. You have mismatching information, and then there's this whole question of whether or not the interaction or the effect that is being seen is due to a disease, or is it due to the drug. So the reports in general are unclear. Some of the interaction studies are limited to animals, and some of them are theoretical. They might be in vivo, so or in the test tube, and in vitro rather than in vivo, so rather than in live people. There's a ton of theoretical interactions that you'll see listed, but very few case reports. So we really need more research to be able to understand the mechanisms behind it and the clinical significance. And I think that's the key is, what is the clinical significance in humans? So we have an increasing prevalence of legal medical cannabis use amongst various patient groups. For example, you're going to see an influx or a heightened use of medicinal cannabis, for example, in the elderly. You will generally see, greater use may prompt greater rates of adverse reactions, may prompt a drug interaction reporting. Oftentimes, the way the drug interaction is kind of even identified is when somebody has a adverse reaction, and then people will go back and look at whether or not interacting drugs were perhaps responsible for making one drug to pushing one drug's metabolism or inhibiting one drug's metabolism, resulting in high levels of that drug causing the adverse effect. And so, we may see that down the road as the prevalence of medical cannabis increases. And the other thing is there's government data collection. So you're going to have universities, government organizations really monitoring the use of cannabis and its adverse reactions. You may have additional reporting mechanisms put into play so that we'll have a better body of evidence around drug interactions in general. Now, in terms of, so when you go and look this stuff up, it gets rather confusing. There's a lot of, you can have 2 or 3 different articles that will report different enzymatic interactions. And generally speaking, cannabinoids, there are substrates of the cytochrome P450 enzymes. So the cytochrome P450 enzymes are primarily found in the liver, and they're also in the intestines as well. But generally, for our purposes, the metabolism is occurring, in the liver. So THC is primarily metabolized by 3A4 and 2C9. CBD is primarily metabolized by 3A4, 2C9, and 2C19. So it's this 2C19 that is the difference between the two. You also have cytochrome 1A2 and 1A1, and these are induced by smoking in particular, cannabis. And when they've looked at studies on this, it's induced by, so they actually did it using joints. And so it's, if somebody is inhaling 2 or more joints per week, that's when they saw the induction in these enzymes here at 1A2 in particular. So what we have here is that you can have a potential increase in THC if you have inhibition or reduced function of 3A4 or 2C9. You can have, similarly, inhibition or reduced function of 3A4, 2C9, and 2C19, which may cause an increase in CBD. You can have an enhanced or induction or enhanced metabolism of the above, and then you will get a decrease in THC and CBD. So it basically means that these enzymes are being ramped up. There's more metabolism through. THC and CBD are processed faster, excreted faster, and you have a drop in both of those. The reality is that most cannabis products are a combination of CBD and THC. So the interactions may involve all of these enzymes. And there's also reports of inhibition of cytochrome P52, 2D6, and 3A4 that has been cited as well. Now, what I've done here is I've just basically put the drugs that have had case reports or documented evidence that they have an interaction with THC or CBD. What you find in this area is a lot of theoretical interactions. A lot of enzymes will be listed, 3A4 and 2C9 and 2C19 and 2D6. And then every drug in the book that you can think of that is going to interact or be processed through those enzymes is listed as a potential interacting medication. So generally speaking, so these are some of the ones that are medications that we really should look for as potential interactors. So you have increasing or decreasing dilantin levels, so phenytoin levels, that may also have variable effects on THC or CBD. So that one's a pretty easy one. If you have somebody on medicinal cannabis and they're on dilantin or phenytoin, you could do levels, phenytoin levels, and just monitor for effect. Now, the CBD and clobazam issue is quite well documented. So CBD can increase the levels of the active metabolite of clobazam, and that's primarily from where it was used in the pediatric population. So you had high doses of CBD in those instances were used. So we don't know if it's if a low level of CBD is really going to cause the same effect. But generally speaking, if you have somebody on CBD and clobazam, you would want to make sure that you're monitoring for increased effect from clobazam to the point where side effect monitoring generally, you may want to lower this dose of clobazam as well with the anticipation that CBD may bounce this up. The other interaction here, generally, THC and CBD is with warfarin. So some documentation that warfarin may increase INR, so warfarin being an anticoagulant or blood thinner. Interaction here can result in an increased INR, which can increase your rate of bleeding, potentially, if the INR, kind of it goes out of range. So this one is a fairly easy interaction to manage. You just monitor the INRs, monitor for bleeding, with the anticipation that perhaps you're going to have to drop the warfarin dose. Now, when back when I was doing the managing an anticoagulation clinic, we saw it a few times, but the warfarin is so variable in that there's many other factors that can increase your warfarin levels. There has a ton of different drug interactions, so we were never able to discern whether or not it was truly the medicinal cannabis. But I've seen it a few times, but not enough to say on a practical level whether it always has an effect. But it has been documented. The other one is rifampin. So rifampin, being an inducer, can drop your THC or CBD levels. Ketoconazole is another one that there's case reports. Again, it can increase your THC or CBD. So if you have someone on ketoconazole and you would want to monitor for essentially any kind of excess kind of side effects from THC in particular. So it's just heightened THC monitoring in those individuals. Theophylline it's used in asthma patients. So the levels of theophylline can decrease more so if you're smoking cannabis. That's when the 1A2 is induced. Cyclosporin, used in transplant patients to prevent a rejection. There's some thought that it may, in vitro anyway, drop, the levels may drop with medical cannabis or cannabis in general. Some of these things were also done with patients who were using cannabis recreationally as well. So they're not, some of what we know has been extrapolated from that group. Tacrolimus as well, potential for increased levels. Clozapine and olanzapine, there are two medications that might be influenced if smoking is suddenly stopped. So, when you're smoking cannabis, your cytochrome 1A2 levels may increase, it'll increase, resulting in more metabolism. And then if you suddenly stop smoking, there's a possibility that your levels of the drug that was metabolized via that enzyme are going to cause an increase in levels of the substrate. Increased topiramate levels, specifically with CBD, zinosamide, not available in Canada, but you can potentially see an increase in levels there. So zinosamide is used in Parkinson's and epilepsy management. These other two, I don't really see these very commonly, but rifunamide is also is anticonvulsant. Possibility for increased levels there. And you'll also, there's one more here, where is it? Right, the riflunamide levels increase when used possibly with CBD. Now, these are all potential, so I just want to point this out. These are potential interactions. By no means, is this necessarily going to occur. If we had to pick out all the ones that, medications where there could be an interaction or is a potential, this is the mixed bag of what I would say is probably has some case reports behind them to justify keeping a close eye. The clobazam one is fairly well documented. The rest of them, the ketoconazole one as well. The other ones are hit and miss. The other issue is not necessarily direct drug interaction, but the effect of using cannabis with another drug that's going to cause a third effect. In this case, it's valproate use and CBD. There has been a reported increase in liver enzymes there. Now, the other thing that you'll find is that when you're looking at various studies or references, and oftentimes there's medications that are mentioned as being interacting but the there isn't any context given in terms of whether that was clinically significant or not. And I've kind of listed some here that you may find, and whether they were an issue or not. For example, you'll have an enzyme listed, and somebody will say, "Well, antivirals, interact with cannabis." Well, no, not all of them do, and some of them do, and some of them don't. Some of them to a greater degree than others. So for fluoxetine, there has been a note of increased hypomania. So this just means there's mania and there's hypomania, which is a little bit less than actual mania. Chlorpromazine, decreased levels when cannabis is smoked. Nelfinavir, so some of the antivirals. So there was a report of some decrease in levels, but it wasn't considered clinically significant. Indinavir, again, some decrease in levels, but not considered clinically significant. Omeprazole also, you'll see it flagged from time to time. Again, no change, no significant change in levels. And we also had naltrexone, and this was just related to a possible enhanced effect of THC. Now, what about in general? So in general, alcohol itself can potentially increase THC levels, but there's also an additive effect on the CNS system. You will have opioids, CNS system additive effect, benzodiazepine. So some of these things were touched upon earlier. Barbiturates, all CNS effect enhancers. You'll have sympathomimetics. There you're monitoring the cardiovascular system, so you may see hypertension, tachycardia. Again, this is if you're using these in addition to medicinal cannabis. Anticholinergics, you're monitoring for tachycardia, changes in CNS, so both CVS, cardiovascular system, and central nervous system effects, and you're looking for ataxia. And antidepressants and antipsychotics, you're looking at the CNS. Now, you might be wondering, well, you probably shouldn't be using medicinal cannabis if you're an antipsychotic, and that's true because it's a contraindication, but some patients will continue to use THC products in spite of any recommendations not to, so that's why that is there. So what if we look at the actual product monographs from Sativex and from Epidiolex, so the two drugs that have, two plant-derived drugs that have been approved for use. So this is coming directly from the product monograph. And again, it's very general. Caution should be exercised for medications that are running through the 3A4, 2C19, and then they kind of rhyme off a bunch of medications that may or may not have an interaction here. Ketoconazole, they do go out and say and reference that there's an increase in that. And then when we further along, so the drug similar to rifampicin, they do mention that drug, as was previously discussed. And then so again, 2C19, they mention omeprazole as well, no notable change. And this is direct from their product monograph. So you can see that it's pretty general. You may not get a lot of information from them in terms of specifically which interactions are going to occur and which are clinically significant. So Epidiolex, so they do also mention the clobazam issue. So there's an increased risk of clobazam-related adverse reactions. And that's part of, just going a little bit back, so that's part of the reason why this is all important, right? I mean, the interactions that occur can increase or decrease some of the other medications, and if you're going to do that, you may have an increase in the adverse effect from the drug that was increased, or perhaps you have a drug that no longer is going to work and cause a breakthrough seizure, or in the case of increased INR, we're talking about increased bleeding episode or hemorrhage. So there is consequences to these potential interactions. But generally speaking, if you're looking at from a high level in terms of the concern around drug interactions and medical cannabis, it's not as severe as, for example, something like amiodarone or some of the other drugs out there. The interactions that do occur are rare. There are a lot of theoretical interactions because when you're going through 2C19 and 3A4, potentially 2D6, your chances of interacting with 2C19, your chances of potentially interacting with multiple drugs are huge. So I think the goal or the value is really trying to figure out which interactions are of concern and which interactions are something that you should monitor for, because there's no way to monitor for everything that is going through those enzymes. Let's just see here. And now there are some other enzymes that I'm not going to go into. They're the UGT1A9, UGT2B7. So we'll leave that. I think that if we can wrap our heads around 2C19 and 2C9 and 3A4, I think we're good. So the other interactions, this is just part of the monograph for Epidiolex. The other interactions, again, they'll list a series of interactions, a series of enzymes, and then their statements are typically that these drugs may potentially interact based on their enzymatic metabolism. And that's it. Any questions on that? Sure. Yeah, it's interesting that you asked that question. We actually have a division called NAC Bio, which is going to look specifically at that question in terms of. So that is a hot area of research, and I don't know if the MedRelief rep is still here, but they are looking at doing genetic screening and genetic testing to see if what enzymes you're coded for are a determinant for how you're going to react to medicinal cannabis. In fact, we're going to be doing our own research on that. This was not a planted question. This is purely coincidental, but we're actually doing our own research. And tomorrow, Dr. Tyler Wish, who's the director of NAC Bio, is actually going to be discussing personalized, in a way, personalized medicine. So let's say you take somebody's DNA, you analyze it, and from that, is there any way that we can customize somebody's medicinal cannabis and give them just the right perhaps percentage THCs, because as you can see here, it's basically what you're encoded for. So some of us, each of us, may react in a different way based on if we have more or less of those enzymes. And so if you're able to tell, right off the bat what which enzymes that you have more or less of, you might be able to predict which strain is, or I should say, chemotype is the most effective for you. So that's actually research that we are going to be doing, and if I can go off on a bit of a tangent, the partner pharmacies and physicians that we do link with will have the opportunity to be involved in that research. So I know that MedRelief was doing something. I think they, as far as I know, they put a hold on that program. So I don't think it's ready for prime time. So I don't know that anybody is doing it now. I know that we are looking at doing something along those lines. But I would think that, so I think the studies, I don't know if the studies are there to prove that it would be of benefit, for example. I know when pharmacogenomics was done for, let's say, anticoagulants or warfarin, it was determined that the expense of doing DNA testing, et cetera, might not really show through in the benefits. And so that's what we're looking to do as well. We're looking to figure out whether genetic testing is going to actually make a real world difference in outcomes in terms of, is it going to improve your knee pain because you were put on a chemotype that is more customized for the enzymes that you are currently coded for. I don't know if we know that yet, but I think that is the future. That is an area of future research, though. Everyone still awake? Yeah. Okay, that's good. Now, so this is where we get to the fun part. So you've heard about vaporizers. You've heard about patients. You've heard a few times now that we recommend vaporization over smoking. Inherently safer. You get more product to the site of action. So what we're going to have now is we are going to break up into groups, and those vaporizers that you see on your table, our talented cannabinoid educators are going to show you how to use it so that you are able to perhaps just get a greater understanding of some of the little intricacies that are involved, and yet how easy it is to do. And also, they're going to just go through the temperatures that you would typically vape at, et cetera. So we're going to get Jane to come up. This event, by the way, is not possible without Jane. She's right there. She's shy.
Hello, everybody. Obviously, I'm Jane. I'm a senior cannabinoid therapy assistant with NAC's Toronto clinic, and I will be one of 4 that will be demonstrating the vapes for you. Second, there's Ailey, right at the back. Ailey, if you can wave. So Ailey is our manager, also CTA at the Toronto clinic. Then there's Sarah, fellow CTA. So we are going to be demonstrating the Solo 2 and the Argo provided by Airizer, and then that'll be phase 1. Once we're done with that, shouldn't take more than 7 to 10 minutes, I assume. Evan, our business process analyst and national clinic coordinator, is going to be over here at the panelist table showing you our stationary vaporizers. So we have just get the name, Volcano, and the Extreme Q. All right, so if everybody can group up, you guys aren't kids, so wherever you see CTE, if you guys can stand up. Ailey's going to be at the back. Sarah's right there in the corner, and I will be here in the front. As soon as we're done, we'll tell you to move on to Evan. Thanks.
So the other one you guys are using is the Mighty? No, it's just the Volcano, right? Yeah, Extreme Q isn't a Health Canada approved, right? Just to add, by the way, the Volcano is a Class 1 medical device. It's actually approved by Health Canada for use.